Welcome to On Becoming a Healer. In every state in the United States, there's an online database that doctors and prescribers can check whenever they're planning to write prescriptions for what the U.S. government calls controlled substances. Controlled substances are drugs like opioids, such as morphine, and they include many other medicines like sedatives and even testosterone. The prescribers are often required to check by their state medical boards. They're expected to look to see if the patient has gotten prescriptions for those same medicines from other prescribers, potentially at the same time. And here's something kind of curious about this system. It's not just prescribers and pharmacists, but also law enforcement who has access to that system. And that raises a question. What does it mean when doctors, pharmacists, other prescribers, and law enforcement all use the very same system to take a look at the very same prescriptions, patients, and prescribers? That's a topic of great interest to Professor Liz Chiarello, the guest on our podcast today. Hello, Dr. Chiarello.
Hello, how are you?
I'm fine. It's great to have you. Can I call you Liz?
You can.
Liz is Associate Professor of Sociology at St. Louis University, where she conducts research at the intersection of medical sociology, sociolegal scholarship, and organizational theory. For Liz, the U.S. Opioid Crisis has presented a case for understanding how two fields, healthcare and criminal justice, look at the same problem. And in late 2024, she published a book on the basis of her work. It's called Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis. It's published by Princeton University Press. So we're really happy to have you, Liz, and I'm looking forward to this conversation.
I'm really happy to be here.
At this point, I'd like to ask my co-host, Saul Wiener, why is this topic one that fits with the general interest and subject of our podcast? How did we get here?
So, looking back at some of the episodes we've run in recent years, I've noticed that this is actually part of a pattern. We did an episode in November of 2023 with the title Drug Testing at Time of Birth, How Physicians Are Co-opted into Harming Families While Thinking They're Doing the Right Thing. There was another episode called My Patients in Shackles, Can We Take These Off? And that was in April of 2023. In that episode, we talked about patients who are literally left in shackles while hospitalized. These are incarcerated patients who come in for medical care. And in some cases, at times when they're sedated, intubated, paralyzed, literally tied to their bed. We had another episode called Urine Drug Screening, How It Can Traumatize Patients and Undermine the Physician-Patient Relationship Without Helping Anyone. There was an episode that I actually did with you called Opioids and the Physician-Patient Relationship. What are we getting wrong? Which kind of looked at the way in which we tend to, unfortunately, fall back on all of these task-based approaches to ordering things and mandating things rather than focusing on the relationship that we have with patients. So I was really excited when I saw Liz's book, Policing Patients, which looks at this from a sociologist's perspective. And, she focused on one particular technology, and that's the prescription drug monitoring programs, or PDMPs. I was sort of jotting down all the reasons I think on why physicians tend to fall back into this unfortunate pattern. First of all, physicians can be judgmental towards patients. Unfortunately, they can be racist. They can sometimes simply try to do things that they feel will protect themselves legally. Sometimes they have the impression that what they're doing is simply good for patients. And so I think that all of these require, for those of us who are physicians and other healthcare professionals, self-reflection. We need to start understanding, why are we doing this and how can we do better? And I think one of the points that Liz has made in her writings that I think is so interesting is you can use the PDMP and feel like you've done a great job because you just identified they're getting meds from other healthcare professionals and you call them out for it and you're not giving them any more opioids and you feel good. But the one thing you haven't done is actually help them get the treatment they need. So it's this weird way in which we can feel self-satisfied, but actually have utterly failed. So anyway, those are some preliminary thoughts. I look forward to hearing Liz's perspective.
Liz, I really want to make sure that I described how a prescription drug monitoring program works. I use one. I'm required to. Did I describe what it is? Is that accurate, what we said in the introduction?
It is. So PDMPs are surveillance technologies that allow healthcare providers, physicians, and pharmacists to monitor patients, and that also allow law enforcement to monitor healthcare providers and patients. And so, yes, it's the same technology being used in two different fields to two different ends.
I just to double check that. I did say that law enforcement has access, but you said monitor as if they might be looking at it more than I thought. Should I be worried?
That's the question, isn't it? It's tricky. It's hard for me to say about you specifically because I don't know
Okay.
your prescribing practices. But I think this is a question on a lot of doctors' minds is, if I'm monitoring my patients, is law enforcement monitoring me? And if so, what would I have to do to go above the threshold to be kind of beyond the scope of practice in a way that law enforcement would find problematic? And what I would tell doctors is the fact that they can see you does not necessarily mean that they will go after you because law enforcement only has so many resources. But I think there's a lot to think through in terms of how providers are interpreting their enforcement environment and how their enforcement environment actually operates that I think we can get into in our conversation.
These databases usually look like a web page. That's the ones that I've been looking at. Is that your understanding as well?
Yes.
You log in, you check. And if I understand this correctly, in different states, there's different rules about when law enforcement can take a look. That in some cases it's pretty open, they can kind of peruse, and in others they have to have a specific reason. Is that also true?
I think they always have to have a specific reason.
Oh,
It's just a question of whether or not they're on the honor system. So in some states, they have a login and they can go in and, I'm working on a case against Dr. Jones. And so I can look at Dr. Jones's records, but nobody's checking to make sure that that's what I'm doing. In other states, they have to have a warrant or they have to have a subpoena. And so they ask for specific information from the agency that's running the PDMP. And so the way that they get access varies.
and I alluded to pharmacists having access. Are they expected to check when they're filling a prescription for somebody's Lortab, Percocet, hydrocodone, testosterone, or not?
There's been a lot more pressure put on pharmacists to check the PDMP, and I think that's largely because pharmacists often work for really large chain pharmacies, many of which have been sued even before this most recent set of litigation
Hmm.
against pharmacists and drug distributors and, the big multi-district litigation. For example, I'm thinking about the 2009 lawsuit against Walgreens that was at the time, I think, one of the largest settlements around opioids that had been paid by a chain pharmacy. And so after that, Walgreens got very interested in making sure that their pharmacists were checking the PDMP
Uh-huh.
before dispensing opioids. And so I think it has become much more systematized into pharmacy work than it has into medical work.
If they check, are they allowed to not fill the prescription?
Yes, they are allowed to not fill the prescription. Pharmacists practice under their own licenses. And
Uh-huh.
this was something that was very interesting to me as I started getting into the research because I thought what I think many people think, which is that pharmacists just fill whatever it is the doctor writes, that they're really just there to dispense. But actually, pharmacists practice under their own licenses and they have the option of refusing to dispense prescriptions in most cases as long as there's a medical reason. If there's a moral reason, their state law varies about whether or not they're allowed to do that. But in general, yes, they can refuse to dispense a prescription that they think is medically inappropriate.
So here we have a tool. It's potentially a tool that some are going to argue is helpful. Can you summarize your argument about why you believe or judge that this tool has been deployed for providers like me to police patients? That's the expression on the cover of your book.
That is the expression. Yes. It might help if I tell you a little bit about what motivated the project.
Thank you.
Um, I was really interested in looking at how two fields, healthcare and criminal justice, deal with the same social problem, in this case, the opioid crisis. And as the opioid crisis was really starting to gain national attention, I saw that healthcare and law enforcement were trying to work together to solve the problem. They were holding conferences together. You had police chiefs saying things like, we can't arrest our way out of the problem. This is really a mental health condition, or this is a medical problem. And that was all really interesting because these are two fields that really are trying to accomplish different things. They attract different kinds of workers. They tend to try to solve problems in different ways. And so I
Yeah.
thought, how is this going to go? Are they really going to be able to collaborate? Or is one field really going to take primacy and it's going to be their goals and their ways of making sense of the world that are going to shift how we contend with these social problems? And so shortly after, I started to learn about prescription drug monitoring programs. And I thought, well, this is fascinating because this is really a law enforcement technology that's being used in healthcare spaces.
Hmm.
And so you could imagine that that technology would transform, that it would become a healthcare tool because it's being used in a healthcare space,
Hmm.
or that it would transform the field itself. that it would reorient healthcare providers toward surveillance and enforcement and away from treatment and care. And that's what I find, that as healthcare providers start to use this tool more regularly, in addition to a number of other pressures. I mean, of course, the CDC guidelines, the rising rates of overdoses, all kinds of other processes are at work.
Hmm.
But as all of that is happening, they start to think more about, how can I make sure that the patient I'm dealing with is really a pain patient and isn't somebody who has a substance use disorder or somebody who is diverting medication. And then they're using the PDMP alongside other kinds of policing tools, most notably the pain contract, which is a legalistic document that sets the parameters of care, but also urine drug screens and sometimes random pill counts. When they say,
Hmm.
show up at my office within 24 hours, I'm going to count the number of pills that are in your bottle. And the reason that's policing is because, imagine doing that with any other medication.
Hmm.
You're on antidepressants. I'm going to text you and you have to show up at my office. I'm going to count how many pills remain in your bottle. We just don't do that for other forms of care. And so these are processes that look like techniques that parole agents use more than the techniques that we think that healthcare providers use. And so that's why we can think about it as policing.
I could imagine someone hearing you say that and think, hey, I practiced medicine. I can actually say this truly. I practiced medicine for a good number of the last 25 years and have been in situations where people were seeking medication so that they could take some, but also sell some. In fact, I once had a patient tell me, hey, I need you to write another script because I'm intending to sell it. And given that the situation around controlled substances that are psychoactive and very often have street value. Like the situation kind of forces us to do this. It's not the police doing it or the PDMP, but like the problem itself. In 2005, when I had a patient say, "Could you do another script so I can sell them?" Like, was wait a second. There are people who literally want these scripts to sell. If I see the evidence potentially of that behavior, it would be wrong for me to prescribe. And so, this level of monitoring that could be seen as policing might just be almost demanded in the nature of the drugs that we're dealing with. Is that a fair argument?
I think it's a complicated argument
Okay.
because, on the one hand, I think you're right. The social problem certainly puts doctors in a really tricky position because legally, you're working under the Controlled Substances Act.
Oh, yeah.
And it says that you have to engage in good faith prescribing for a patient with whom you have a relationship and for a legitimate medical purpose. And so if you have a patient who's saying to you, I'm planning to sell this medication, well, that's not a legitimate medical purpose and that's not legal for you to prescribe.
Uh-huh.
But you also have a set of ethics that you have committed to. When you went to your white coat ceremony and you raised your hand and you took an oath, you also committed to care for your whole patient. And so knowing that your patient is selling their medications tells you something about what's going on in their life. Or if they're taking too many pills, given what their diagnosis is, you know that there's something else going on. And as a provider, you tend to want to help your patient to figure out what else is happening, and use all of the tools in your toolkit to make it better for them. And just cutting them off or firing them from your practice is not usually in their best interest. And so that's where I think things get really complicated. I'm
Huh.
not saying get rid of the PDMP and prescribe everybody an opioid who wants one. I think that would be really reckless. But I am saying, let's be really careful about how we're using these tools and what we're expecting these tools to do.
One thing that came out in your book is that there were people you spoke to who sounded to me like well-intentioned doctors who said, "You know what? This really helped me do a good job." And I feel like sometimes I've had that happen too, where I saw a patient who seemed to be asking for, I think it was an opioid, but kind of high dose. And in that instance, it wasn't that they were selling it or whatever. I went and looked through their record and realized, oh, they've been in much, much higher doses in the past. They've actually been coming down steadily, but they're now new in my practice. And I can justify prescribing this dose that's higher. All these people saying, who are good faith doctors saying this really helped me, do we accept them on face that when they say it helps them do a good job, that it's helping them do a good job? Or are you asking questions?
Well, I think I do ask questions while at the same time I want to believe that what people tell me is true. So when people tell me this is a helpful tool, I believe them, that it is helping them in some way to do the work that they're doing, and it makes them feel better about the work that they're doing. I think the challenge is that what counts as good practice has changed significantly over the past 20, 25 years, and that doctors have gone through a bit of a whiplash. For a minute, the narrative was pain is the fifth vital sign. You really have to treat everybody's pain. It's going to go into your patient satisfaction scores. If you're not adequately treating pain, there could be legal repercussions for that, to where we are now, which is, you've got hospitals celebrating having opioid-free ED policies. You have doctors sending patients home with almost no opioids after surgeries. I mean, we've really gone from one extreme to the other.
Hmm.
And so, yes, I think that there's a difference between the information being helpful to a provider and the particular system being helpful to a provider. So, medicine is really fragmented, and doctors often do not know what other doctors are doing unless the patient tells them. And so everybody's kind of flying blind unless you happen to be in the same system and share the same electronic health record. But otherwise, you don't really know who your patients are seeing or what medications they're getting. And so, what the PDMP does that I think is really good is it aggregates all of that information into the same system. And so everyone can get that information at the same time. And so
Hmm.
when doctors say that's useful to me, I believe them. That
Hmm.
seems like
Yeah.
something really useful for making good decisions. At the same time, the PDMP was not designed to be a healthcare tool, it was designed to be a law enforcement tool. And so if that information, for example, was in the electronic health record and other providers had access to it and pharmacists had access to it, then that would be healthcare having a conversation with healthcare. But
Yeah.
this is healthcare having a discussion with law enforcement. And I think once you cross those lines or blur those boundaries, that's when we have to start thinking about the value of the tool versus the value of the information.
And is it the case that prescription drug monitoring programs are really not in healthcare records, but are sitting on usually on servers hosted somewhere between a state agency, a vendor, usually the same company called Bamboo? Like it's not really a health record itself. It's not subject to health record protections by law, right?
It is not. It's not protected by HIPAA. And yes, it's developed through a public-private partnership with whichever the state agency is. Sometimes it's the Board of Health or the Board of Public Health, the Department of Justice, the Department of Consumer Affairs. It varies state by
Hmm.
state, but it's them and whoever the vendor is. And in many states, the vendor is, it used to be Apris, it's now Bamboo Health. And so, no, it doesn't count as a health record. And so it's not subjected to the same privacy protections as the rest of your health record, which is interesting and surprising.
Right, because it kind of sits outside. Part of what I read in your book is, look, doctors may cut patients off of medicines. They may kind of send them to the street. They may actually improve care with this information, or they may somehow turn the patient over to law enforcement. But I kept wondering if you were also arguing if using this system, maybe this and also urine drug tests, are you arguing that I become an inner policeman? Like that there's a part of me that's already inclined to be a policeman for whatever reason. I watch police procedurals on TV all the time. I'm always trying to figure out who did it. Did you get any evidence from your work that something about this interaction leads us to potentially feel like we are policing our patients, begin to think, I got him, I got him. Is that one of your points?
Not exactly. I
Okay.
I see I see where you're going with that. What I'm arguing is more on the level of fields than on the level of the individual provider.
Oh, you're
What
a
I'm essentially
sociologist. I
I'm a
remember now.
sociologist, so I am talking more structurally, and what I am saying is that healthcare is becoming a handmaiden in this arena.
Okay.
Healthcare is becoming a handmaiden to law enforcement, and so that you as a provider are being deputized to do policing work. It does not necessarily mean that you then think about yourself as a cop, although I do get some of that. Like, if you look at my interviews, some physicians use this very kind of police-oriented language. They're like, "Oh, we sussed it out," or "We think them do this because of good behavior." They use this kind of policing language. I think that what happens is being asked to be both a medical gatekeeper, which is what medicine mostly is, and being a legal gatekeeper, which is doing this kind of policing. Being asked to do those 2 things at the same time creates a lot of cognitive dissonance
Huh.
because they're basically saying, "Wait a minute, am I a healthcare provider or am I a cop?" And what has resolved that cognitive dissonance for them is that they have reframed policing as healthcare work, and
Hmm.
then they embrace it. And they're like, oh, yes, this is part of my job. And you really see it in the data with pharmacists. When I was talking to pharmacists in 2009, they were like, look, I'm not a detective. I'm not a detective. I'm not a cop. I'm a healthcare provider. I shouldn't have to do all of this work around
Huh.
opioids. But by the time I talked to them again in 2013 or 2015, when the PDMPs were really in regular use, then they were saying things like, you know what, I'm helping. I'm helping by surveilling. So actually, this treatment and this policing are part and parcel of the same thing. And so the dissonance had been resolved. And now they understood this as a key part of their work.
One thing that I found interesting in that section of your book, Liz, is when you were talking to these pharmacists, they would tell you that they had cut a patient off. I looked in the PDMP. This guy was getting narcotics from like three other pharmacies, and I notified them. And I told this guy, I'm not giving it to you, and I had the proof, and et cetera, et cetera. And there's a sort of sense like I did good. And yet, your point was like what this patient may have really needed was methadone and buprenorphine, right? This is a patient who may actually really need a kind of care that is evidence based and that's effective. And the pharmacist doesn't have access to that. It's not something they can do, and it's not part of the loop. And so it doesn't happen. And so you end up with this sense of we actually practice law enforcement, but we didn't actually practice healthcare.
Huh.
I thought that was really interesting because it kind of gets back to this sense that you think you've been helpful, you think that this technology has done good, but then if you stop and say, wait a minute, I'm a healer, I'm somebody who's a healthcare professional who is dedicated to helping people, then you think, well, wait a second, I haven't actually done anything because this patient could just as easily be forced into the street to now buy these drugs illicitly and end up with like synthetic fentanyl and then they're dead. And so, it's not like just cutting them off without any plan was just somehow a step in even the right direction, other than it being in the right direction for law enforcement. It certainly there's no evidence it was in the right direction for the patient. And it certainly didn't give them access to things that are evidence-based and beneficial. So I just thought that was interesting because it's stuff that you don't think of when you get into
Yeah.
this mindset of feeling like I'm just doing what this system tells me I'm supposed to do.
Well, and I think that's a really good point, and I think the key here has to do with what are the tools in our healthcare providers' toolkits. And the challenge with pharmacists is they have a lot of discretion, but the discretion that they're largely able to exercise is saying no. So they're able to say, I will not dispense this for you because I don't think it's medically appropriate. But they can't say, so I'm going to do this other thing instead.
Huh.
And so they can say, I'm not going to dispense these opioids because I think you have a substance use disorder. But I asked them, so a substance use disorder is a medical condition. What medical tools do you have in your toolkit to help those patients? And they mostly told me, we have nothing. And sometimes they said to me, well, I have a list of treatment facilities in the
Oh,
area.
wow.
But that's not a referral to treatment in the way that we normally think about referrals in the healthcare system. And so pharmacists are in a place where they can cut patients off. And then doctors who do have more tools in their toolkit are also often in a position where they're pressured to cut patients off because
Yeah.
they're afraid. They're afraid that if I keep prescribing for this patient, law enforcement is going to come after me. Or this patient's difficult and I don't really want to deal with them. And so I can justify cutting them off. Or the CDC guidelines tell me that I can do X, Y, or Z. And all of this is used to justify cutting the patient off instead of getting the patient better access to care.
I want to confirm and agree with the sense that somehow in the world that I practice in, of my state, the board would like me to not prescribe when certain thresholds are not met. And certainly a PDMP record that looks like there's a lot going on is another place to not prescribe. But the board doesn't have expectations listed out about how you would respond that would help the patient. That's not a part of the board rules in my state or in most states where I've checked this up. On the other hand, I do want to, since you mentioned the CDC, I should acknowledge that we've been through a sort of a sea change from 2016 to 2022. And I don't know if they'll be listening, but clearly their first guideline really kind of gave a lot of people a way to stop prescribing without reference to what happened afterwards. And if one were to take the next version seriously, it seems to say, look, be really careful here if you're about to reduce prescriptions. I don't know what's happening. I don't think it's happening in reality, but I think the agency tried to adjust course.
It's so hard because when things become institutionalized, it is very hard to unravel them. And so the 2016 CDC guidelines were almost immediately treated as if they were law. and they
Hmm.
became woven into a lot of different systems. And so
Mm.
even though the guidelines have changed, the other ones are still embedded in these systems,
Yeah.
and even if they're not part of official policy, they've really become part of practice. And so it's very hard to change behavior and it's hard to change practice, especially if that practice makes providers feel safe. And so it's great that the guidelines have changed, and a lot of people did a lot of hard work to get those guidelines to change. But then translating policy into practice is another uphill battle.
Okay, now this, I agree with you, but let's ask this question. PDMPs are a tool, they've been deployed across states. Do we have evidence that if you deploy them or if you mandate that they be checked, that patient safety improves or that overdoses go down? I mean, surely there's lots of studies. I took a look. What did you find?
I'll start with the overdose question. In terms of their impact on overdose, it seems like there are really mixed results. It seems like in some cases, overdose seems to go up after PDMPs have been implemented, and in other cases, they go down. And so we
Mm,
would really want to know what the mechanisms are. But I have seen pretty consistently that PDMP implementation leads to declining rates of opioid prescribing.
yeah.
And, it's interesting to me to think about when PDMPs were envisioned versus when they were implemented and how the crisis has changed over time.
Huh.
Because, of course, we've gone from what we can think of as a prescription opioid crisis, or some people have framed it that way, to a heroin crisis, to a fentanyl crisis. Now we're heading into xylazine and all kinds of other drug problems. Okay, so as the drug changes and the crisis changes, and we're in perhaps the fourth wave of the opioid crisis, the solutions have not changed along with them. And
Huh.
so the PDMPs came around at a time when the crisis was already changing. It was already shifting from prescription opioids to heroin, and perhaps PDMPs helped to facilitate that shift. But cutting down on the prescription of legal opioids is going to do little to nothing to stop people from overdosing on fentanyl.
Oh,
And in fact, there's an argument to be made that by shutting people out of the healthcare system, you increase the likelihood that they're going to use drugs through illegal markets and as a result overdose on fentanyl. So you might actually be doing more harm than good by cutting patients off
yeah.
of these medications or by making these medications less available in illegal markets. And that is it's a complicated argument, and it's a little bit uncomfortable to make. But at the same time, in as much as the prescription drug supply is the safer supply, cutting off the safer supply really does lead people to look towards worse alternatives or more harmful alternatives in this kind of iron law of prohibition
Yeah. Which,
mechanism. So if prescription drug monitoring programs are reducing opioid prescribing, but are not also reducing overdose rates, then we really do have to question the role of the PDMP in solving this crisis, which is an overdose crisis, not an opioid crisis.
for people who may not have understood the reference there to iron law, there is a debate about this, but is certainly a substantial cohort who would say that when you create restrictions or prohibitions on one set of drugs, the demand might essentially get funneled elsewhere and very often to a more dangerous subset. Think of people maybe going to illicit forms of alcohol during prohibition in the United States in the 1930s, which were actually more dangerous. There is a counter argument, which is that supply begets demand. If you make sure there's lots more drugs to get, more people will seek them. So there's a back and forth, but I think
Mhm.
your point still stands, and all the literature I saw was decidedly mixed and unclear. I didn't find anything compelling to suggest that on whole, prescription drug monitoring programs saved lives.
I do want to pick up on a theme that I've heard resonating across, as I said, several episodes of podcasts we've had on different ways of looking at this phenomenon of we as healthcare professionals policing patients. Mishka Turplin, who is an obstetrician gynecologist who we interviewed for the episode on urine drug testing and pregnancy, said that drug use during pregnancy differs little by race and class, yet people who are poor, Black, or from other historically underrepresented and underserved communities are more likely to be tested, reported to child welfare, have a child placed in foster care, and have their parental rights terminated. And then our guest today, Liz also writes, choices about who receives opioids depend on whether providers consider patients deserving or undeserving. Evaluations grounded in the same modes of discrimination, racism, classism, and sexism that plague the legal system. And so I am interested in hearing Liz's thoughts on the way in which our biases tend to amplify the problems that she's interested in. I mean, one of the things that she says in her book is that, for example, pharmacists don't have to activate the system all the time. They may choose to look for some patients who, quote, look suspicious, but not for others. They may choose to act on the information subjectively based on what they find more so than with others. And so there's this sort of layered set of biases that affect and drive decision making, causing inequities. But ultimately, what you see at the bottom of the chain is a harm. In the case of urine drug testing in pregnancy, it's actually losing your child, which is obviously a catastrophic outcome. And for a patient coming into a pharmacy, it could result in ending up desperate and on the streets. Whereas a similar patient, from a risk perspective, may not end up in that situation. So it'd be helpful, Liz, if you could talk a little bit more about what you learned about the way in which these biases play into decision making with the PDMP.
Yes, I'm happy to. And I will tell you, I really enjoyed that episode about urine drug testing in pregnancy because I thought it hit a lot of really important points and also talked about this same overarching theme that runs through my work, which is about the blurred boundaries between healthcare and law enforcement. And I saw it in the other episode that was about my patient being in shackles.
Yeah.
And
Yeah.
can we take these off? Again, the kind of blurred interests of the healthcare system and the criminal legal system, and what I see across all of those is this interest in making sure that the healthcare system is adhering to its own set of values. And those values aren't being kind of polluted by another system who would use healthcare to its own ends.
Huh.
And so, physicians as mandated reporters, that's complicated too, because, I believe that your guest talked a lot about neglect and how neglect ends up being kind of this catch all term
Yeah.
for
Neglect of an infant or of a child is a catch-all, you're saying.
yes. And so that's a category that's very open to interpretation. And so, what are the factors that are helping to shape that interpretation? And to what extent are they race, class, and gender? I think it's also important to think about who uses drugs. And, there really aren't tremendous racial disparities in
No.
terms of who
Everybody uses
uses
drugs.
drugs. Everybody uses drugs, but who gets caught for using drugs and who gets punished for using drugs? And so the consequences of drug use really vary across race, class, and gender, even if the use of drugs doesn't vary as much across those different groups. I did interviews. So I talked to people and had them tell me what they did in their practice. And one of the things that sociologists know is that there is a difference between what people say and what they do. And so you can't take what they say as a perfect measure of what they do. And it's especially challenging because interview participants are like everybody else. We want to put our best face forward. And so it was harder for me to get at questions like racial bias, for example, because people are very interested in presenting themselves as not racist. And they might not even know, right? There's an implicit bias that might be shaping their decisions that they might not even be aware of. But I did get a lot in terms of class. So people would say to me things like, "Oh, it's the person with the messed up teeth. I'm really uncomfortable with them because the assumption is that they're using meth." But dental hygiene is also a class marker. Or they would say, "Oh, it's the guy who comes in who looks a little bit dirty." And so looking dirty, could mean that you're insecurely housed, or it could mean that you're using drugs. And so these markers they were more willing to talk about. But I do remember talking to one pharmacist in San Francisco, and this was my second interview with him. And I said, how are you making these decisions? To what extent are race and class part of the story? And he said, oh, we're using the exact same profiling systems that cops use. We're
Huh.
looking at race and we're looking at class. And his was the most overt that I've ever seen. But I think it's because by that point, he was more comfortable talking to me. I think most people kind of hold those cards closer to their chest, even if that is something that they're experiencing. And so the other challenge, I think, with prescription opioids is that there's a race, class, and gender bias in terms of who gets access to those medications to begin with.
Huh.
So, for example, Black and Latino men and women, and then also white women are less likely to get access to opioids. When they do get access to opioids, they get less powerful opioids in a smaller volume with fewer refills. And so there are many people who have been systematically denied access to opioid care even when they need it. And so I think certainly there are inequalities that are running through these practices in ways that my research isn't entirely designed to get at
Yeah.
because of that challenge of what people say versus what they do, but that we can certainly see in more statistical approaches that compare groups and access to care.
I think it would be helpful if you said a few words about the Trojan horse framework,
Yeah. What does
which is
that
so
mean?
important. And you've actually already described it, but not named it. And the reason I think this is so interesting is because there's a lot of recognition that AI, artificial intelligence, is now moving more into healthcare, which is obviously a technology. And Stefan shared with me a paper on the NARCS Care score. And that is an AI driven tool that draws on data from the PDMP to inform decisions about risk, but is also fraught itself with a number of some of the same issues that we've just been talking about here, where biases can end up in the AI algorithms and then drive the behavior of healthcare professionals in the same direction that you're so concerned about, which is away from the healthcare or healing mindset into a more criminal justice or punishment mindset. So, if you could just tell us a little bit about why you call this the Trojan horse framework.
Yes, let me tell you that, and then I'll also tell you a little bit about how PDMPs have changed over time that I think get to your point about AI. So I call it a Trojan horse framework because if you think back to the Trojan horse myth, one of the things that is important to remember is that the Trojans were horse people. Like this was kind of their thing. And so, what better symbol to commemorate their victory than this enormous wooden horse? But what they didn't anticipate when they wheeled it behind their gates was that hiding inside were Greeks who planned to kill them. And kill them they did, and they brought an end to the Trojan civilization. And the PDMP works in a similar way in that it looks like a healthcare tool. Healthcare providers have become very accustomed to healthcare technologies,
Yeah.
especially with the rise of the electronic health record. And so
Yeah.
if you look at a PDMP printout, it doesn't really look that different than an electronic health record. But what healthcare providers and healthcare leaders don't realize is that embedded within the PDMP are enforcement logics, by which I mean ways of making sense of the world that are more oriented around policing and surveillance. And so those are actually embedded within this technology so that this technology doesn't act like an electronic health record. It actually pushes providers towards policing because it's designed to be a surveillance technology. It's not designed to be a healthcare technology. And so, as healthcare providers use the PDMP in daily practice, they begin to become more reoriented around surveillance and policing, and it becomes clear with physicians as they use the PDMP alongside other policing technologies like the pain contract, urine drug screens, and random pill counts. And with pharmacists, you see it as their routines shift, their relationships with physicians and with law enforcement shift, and roles change as well. They start to understand themselves and their roles in a really different way. And what results is they route patients out of the healthcare system, either directly into the arms of criminal justice, or they kind of leave patients to fend for themselves. And then patients are vulnerable to law enforcement as a result of that as well.
And street drugs or whatever, wherever they end up going in desperation.
Well, right, because if they're using the street drugs, then they're more likely to be caught by police.
That too. Yeah.
And so then and actually that relates to your inequalities question because the same inequalities that we see in terms of who gets access to care are the inequalities that we see in terms of who is detected, arrested, and prosecuted around drug use. And so there's a cumulative inequality that mounts across these two different fields.
Yep.
And then the other thing I was going to tell you is about the difference in terms of how the PDMP has changed over
Oh,
time.
yeah. I'll just even ask it. So tell us a little bit more about how the PDMP has changed over time.
Well, PDMP 1.0 was basically an Excel spreadsheet. And so if you think about being a healthcare provider, you're a physician or you're a pharmacist, and you have to somehow process all of this information very quickly and very efficiently to make a decision about whether or not you're going to prescribe or dispense. What you have is like the patient, which doctors they've gone to, which medications they've gotten, what volume, when they've gotten them, and you have to do all of that math in your head. Well, that is not a very useful tool. I think the PDMP became more useful to healthcare providers when it started to become more algorithmically sophisticated. This was before the risk score really existed, but it at least would show you charts and graphs that would then help you say, oh, wait a minute, they're using a lot of drugs or they've gone to a lot of doctors. And now the newer versions of the PDMP are more algorithmically sophisticated. And so they actually create a risk score. So then healthcare providers can make decisions based on the risk score. But the problem is they don't know what goes into the risk score. So unlike that original Excel spreadsheet where they actually had all of the raw data, but it was hard to compute in a very short period of time, now they have a very quick and easy risk score, but the risk score doesn't necessarily tell them what they think it's telling them. And so if they're making decisions on the risk score alone, they're really losing a lot of what's happening for the patient. And we're not going to know what's in the risk score because, again, PDMPs are created through a public-private partnership, and the private part of that partnership has trade secrets, and they're not interested in sharing what specifically goes into their algorithm to create the risk score. And then as we move towards AI, the challenge with AI is we know even less about how AI is making decisions than we know when a company creates a recipe for an algorithm. And so things are becoming more and more opaque, even as these decisions are becoming more and more consequential for patients.
I think what you're describing is something we need to name and confront right now, which is that on the one hand, we have this AI that's increasing its impact and influence in healthcare and obviously a lot of other sectors. It is a kind of Trojan horse in that it looks familiar. It can be made to look like something we're used to. As you said, it can look like the stuff that's in the electronic record. It can give us guidance that looks like, the standard algorithms that we learn or have learned about making treatment decisions. And so it can have this sort of familiar feel to it, especially to people who have the mindset of physicians, who have a lot of technical training and so forth. And yet, as you're pointing out, it can be extremely harmful in terms of its absolute lack of interest in whether you are actually helping this person who is in front of you with in this case, problem related to pain, to opioid use disorder, or to many other things, as we've seen on other episodes. And so there's a quote from you in Policing Patients where you say, referring to your own argument, you say, policing patients urges medical providers to reaffirm their roles as healers. And I'd like to turn to that. So again, the phrase here is reaffirm their roles as healers. Can you say a little bit about what you have in mind when you say that?
I think that there are a number of different stakeholders who have an interest in what healthcare providers do and an interest in controlling what healthcare providers do. And we see this often with the legislature, we've seen it with the Supreme Court, we see it with private corporations, and we see it with law enforcement. There are a lot of groups that really want to determine the path of healthcare, who gets access to what kind of care. And physicians are part of a collective that has taken an oath. They have a shared set of ethics, they have a shared knowledge, and they constitute a professional field. What I'm saying to physicians is you, as professionals, have a lot of discretion and have a lot of autonomy, and you should use that to mobilize in your own interests. Because if you don't decide what medicine is, somebody else is going to decide it
Hmm.
for you. And
So
so I would like physicians to reaffirm their commitment to healing, to reaffirm their commitment to helping patients in ways that ward off these other groups that would like to determine what they can and can't do and who they can and can't help.
I think that is such an important point. I want to just pick up on it from the perspective of being a physician who practices. Again, I've fallen back on this before. We tend to be efficient task completers. In other words, we just have this tendency in our profession to just log into something, push buttons, look at algorithms, do what we're supposed to. Oh, I'm supposed to look this patient up. Oh, they've been, getting meds from another pharmacy, or oh, they have cannabis in their urine, or whatever it is. And like, okay, this is what I'm supposed to do. I'm supposed to say, no, I can't, you can't do that. I can't help you, whatever. And when in fact, all of these things are only supposed to be tools. And they're only supposed to be something that doesn't control you. You control it. So, the way you control it is your understanding of what it is to be a healer. And I think that's what Liz is getting at. What does it mean to be a physician who cares for people and then has all of these tools that are often misleading, dangerous, and are often put in front of you with some ulterior motive? And I think that's where the Trojan horse framework comes from. And, somebody is up to something when they put this in front of you. I mean, of course, if you think about the whole opioid crisis, when we started, prescribing these drugs like candy, well, of course, there were things that were being put in front of us that were making us think that that was what we were supposed to do as well. And actually, Stefan and I had a conversation about this, which is the surprising degree to which physicians think they function independently, but don't really. And are so prone to getting sucked into these vortexes and following all of these algorithms and rules and just completely forgetting what they're here for. And I think that's really a critical theme.
Let me take you back to a story I heard from, I think one, maybe two doctors back from 2007, 8, 9, 10. And they were working in a relatively public clinic that served a relatively large impoverished population in an eastern state, probably near Appalachia. And they just got loads and loads of requests for opioids forever. Like, it was just like a giant thing. Everybody was expecting them to prescribe. And there wasn't a PDMP at the time that this was happening that was accessible to them. And they're like, how are we going to deal with this flood of requests that we're getting right now? We've got a solution. They somehow got access to the state arrest records. I think in that particular state, they were posted online. And their view is what we can do is when we get all these patients asking us to prescribe opiates, we'll just check the state arrest records. And if they seem to have a bunch of arrests for drug issues, we'll know we shouldn't prescribe to those people. And that will institute a little bit of order in this very complicated situation that we're practicing in. So, I mean, from their point of view, they were solving a problem that was kind of a flood. And I hear you saying that we should all be healers, but they had kind of a problem to solve and they kind of solved it. Should we acknowledge that they had a problem to solve and they solved it?
First of all, I can say that Liz is looking horrified.
I'm sorry. Did I horrify you?
Liz does not mask emotions well. And so, yes, I think you could read that all over my face. I have several things to say about this, but just to touch on the most recent thing that you mentioned, I mean, here's the thing about arrest records is that arrest records are biased because arrest records are not a good measure of who is engaged in bad behavior. They're a measure of who's engaged in bad behavior who got caught. And in fact, sometimes people are caught who aren't even engaged in bad behavior.
Okay.
And so you're really having to trust the criminal legal system to be doing its job perfectly if you're planning to use their records to help you do your job. And because there are biases in who gets arrested, there are then going to be biases in who you give access to care. And so I think that is not a good measure for who is misusing drugs and who isn't misusing drugs. But I think one of the biggest challenges for physicians, and this goes back to your point earlier, Saul, about being efficient task completers, is at the same time that we're kind of enamored with technology, we are also enamored with efficiency and the way that technology will help us behave more efficiently. But what we probably really need is a much slower role, a much slower way of doing a lot of our work because we could do a much better job if we're doing it more slowly. I think what you talk about, Saul, is efficient task completers. Sociologists talk about as people processing. And so frontline workers like doctors and pharmacists and social workers and teachers, all kinds of people are in a position to process their clients kind of as quickly as possible. And sometimes they will do more than the law allows. Sometimes they'll do less than the law allows. But usually they're doing exactly what the law allows because what they're trying to do is get through these people as quickly as possible. And I don't think that's what doctors tend to sign up for medicine to do. They don't think to themselves, I'm going to go as quickly as I can through as many patients as possible so that my clinic can make as much money as possible, so that I can see as many people as, whatever those motivations might be. No, I think, I teach students who are pre-med and I see their statements of purpose that they send to medical school. And none of them say, I want to see as many people as possible in a day, or I want to police patients. Like, that's not what they're interested in. Usually what has happened is they either have a diagnosis themselves or somebody close to them has had a diagnosis, and that has illuminated for them some of the shortcomings of the healthcare system. And they think, you know what, I could do this better. I'm going to go into this field so I can do it better. And the next thing they know, they've been not co-opted, but certainly transformed by the system because they start to realize the stakes are different than they had hoped it would be. And we all have this. We all have, there's an actual ideal discrepancy for everybody between what they think their job is going to be and what their job actually is. But I think that for physicians in particular, if you had half an hour with your patient, you could do a lot more to help heal them than you do when you have 10 minutes with your patient.
Yeah, I mean, I agree that the time is an issue, but I also want to throw out the thought that there's something that physicians may be lacking in their capacity to engage with people around challenging situations.
Hmm.
And they often say, I just didn't have time. But I don't think it's just a time issue. And let's just go back to the example that Stefan shared with us
Yes, and
from,
it's a real story, by the
yeah,
way.
Uh-huh.
and so you said that they needed to solve a problem, and the question is, whose problem did they solve? They solved a problem for themselves, which is they had all these patients knocking on the doors asking for opioids. But did they solve a problem for the people who were seeking care from them, or from these individuals? And, some of them, of course, may have been drug dealers. But the point is, the problem they were solving was their problem, not the problem of how can I help people, some of whom have serious opioid dependence, chronic pain, and so forth, and reflect on a different approach they might have taken. Imagine if this patient walks into your office. It's maybe the fourth or fifth patient that day, and they say, I'm so and so. I know we've never met before, but I need opioids. I'm just kind of summarizing it, right? It wouldn't quite come out that way. And physician would say, well, okay, let me get to know you. This may not happen in one visit. I want to hear a little bit more about your situation. As you know, opioids can be helpful in certain situations. They can also be very dangerous. They can harm people. As a physician, I've taken an oath to always do the right thing. And so I'm going to do well by you. We only have 20 minutes today. And so I can't guarantee that we're going to solve the problem in one go. But let me hear a little bit more about what's going on with you. And then you have essentially a good faith conversation. Now, at the end of that conversation, you may say to the person, I'll tell you what, I don't feel ready to just make this a long-term situation. I've just met you today, but I can tell that you say you're suffering, you're in pain, your doctor has retired. I will give you some pills for a month, and then you'll come back and we'll continue this conversation. So there are ways in which you can negotiate with each patient. Now, does that take time? Yeah, it does take time. But I don't think time is the whole story here.
Yeah.
You can have these conversations in a fairly short amount of time, particularly if you're making it clear to the patient that you're not going to resolve their whole request in one visit. But I also think that having these conversations requires a certain level of boundary clarity. You have to be able to be very honest about who you are as a physician, what you care about, that you care about them, but that you also don't want to do something that would be harmful to them or untrue to your own oath, and that you're willing to stand your ground on that, but also be caring. And I think the capacity to do that is actually quite challenging. It requires a high level of, I would say, for lack of a better term, emotional intelligence, a boundary clarity, capacity to be open, honest, and engaged. And I think we have to take into account that physicians may not have that.
Yeah.
And when they don't have that, they're going to default to, the algorithmic use of technology.
I really appreciate the point that you're making. It's not just time, it's also skills. If you have all the time in the world, but you don't have the skills, you're not going to be able to address the problem that the patient's having. But at the same time, if you have all the skills in the world, but you don't have the time, you're not going to be
Mm.
able to address the problem either. And so there is one physician in the book, and I know you're not supposed to have favorites, but she was my very favorite physician that I interviewed. And in the book, I call her Megan, not her real name. She worked for a federally qualified health center in Northern California.
Mm.
And, you know, she saw a lot of patients coming in who had substance use disorders. And instead of doing what a lot of physicians that I talked to did, which was basically draw a boundary around their scope of practice and say, look, I'm not an addiction medicine specialist. I just don't do that. She got her X waiver, which was required at the time, and learned how to prescribe buprenorphine. She found that a lot of her patients were in pain. She did some specialized training in pain care. And so what she did was she put more tools in her toolkit so she could actually help her patients. And so I think for a lot of doctors, it's really tricky because, a patient comes to you and you're supposed to have the answer. And I think when you don't have the answer, that can make you feel bad about yourself as a provider. And it's easier to put that onto the patient than
Yeah.
to adopt new skills. Because again, you don't have all the time in the world to adopt every skill. But I think it is really impressive when doctors are able to step back and see what it is their patients need and then find a way to provide that to them instead of trying to find ways to push patients out of their practice or, refer them to somebody else in the hopes that they'll take it over. Because the truth is, most physicians today are not going to take over opioid prescribing. And they are not going to do it, especially for patients who are on high doses, which means those patients are left in a lurch. They don't suddenly not need their opioids just because doctors don't want to prescribe them. And so, where do we think those patients are going to go? And some of those patients will turn to the street, and some of those patients are dying by suicide, which is tragic. But we have to find a way to help those patients. We can't just take opioids out of the medical toolkit and think we've solved the problem.
Yeah, I want to offer my appreciation for the Megan of your book, in particular, that she takes on complicated cases and tries to do them. And it's something I aspire to do. Obviously, I've been deeply inspired by the concern that I've seen, that I've observed firsthand, people becoming suicidal when other clinicians stop them. I think it's absolutely crucial that we recognize that the clinician who takes the time just to understand the patient, to learn what's going on, likely to potentially continue a prescription with some documentation as to why they're doing it, is potentially saving a life, not causing a death. And they're working uphill at this point in terms of the environment that they're in, but they're making potentially a big difference. I'll also mention, because it bears mention, that I know I currently lead a federally funded study to better understand the conditions surrounding suicide that occurs in people with pain whose prescription opioids are stopped. That study is in some risk as a result of current ongoing events in our federal government, but it's very important to me to understand that people don't live and die based on a pill alone. It's a complicated life. But when a clinician recognizes, hey, I have a role to play, I can learn this person's story, I can try to make some sense of what's going on. And if it takes me a few visits and I'm going to continue those prescriptions for now, while we learn what's going on and how a person survives, I'm acting like a healer, like what Dr. Weiner has been pushing in this podcast, and I certainly subscribe to. We can make a big difference. And sometimes it does require taking a slightly contrarian perspective, given that, yes, we overprescribed and we've been pushed to reduce, and we have reduced, but at the same time, we've got to save lives. That's a crucial, important function that we have.
I really appreciate that point. And Saul, I have to tell you, when you were describing that conversation with the patient, right now for a new project, I'm starting to interview pain patients about their experiences getting access to opioids. And I was really putting myself in the patient's shoes. And here is this patient who has been cut off of their medications because their doctor has retired or has gotten out of the opioid business or whatever's happened to their doctor is gone for some reason or has referred them and isn't willing to see them anymore. And here's this medication that they rely on to make themselves feel like they can live a life. The patients that I talk to are talking about, when I'm on my medications, I can spend time with my grandson, and when I am not on my medications, I'm in bed and suffering. And so this is for them a life-giving medication, and they're sitting across from you, and they are terrified that you are gonna say to them, "I won't prescribe you," or "I will prescribe for you, but I'm going to taper you." And so they're terrified. And when you say, "I'm not going to," and you didn't say this, but for some doctors, they say, "Well, I'm not gonna do it this visit. I might do it next month." They're then staring down a month of excruciating pain. But they also have to engage in something that sociologists call a moral performance. So they have to
Uh,
show you that they are deserving of those medications because they know that even if you won't do it right now, but there's hope that you'll do it next month, if they yell at you or they cry or they freak out in any way, that
oh
you
my
might say,
God.
"You know what? This just isn't the right fit. I'm not the doctor for you." And then they have to start over and try to find somebody who's even taking new patients. And so thinking about all that pain patients go through, they finally find a solution. And then they're looking at you as the potential gatekeeper. You're the one thing standing between them and this medication that they know to be beneficial. I just find that to be such a challenging situation. And I think it's important for physicians to put themselves in these patients' shoes and think about all they've gone through to get access to care and what they're afraid of in this conversation with you.
Yeah,
Wow.
no, I think that's well put. I think that, and again, I'm speaking about my personal approach here, which is that when I'm with a patient, my only objective is to see if I can be helpful to that person. And so that requires figuring out what's going on with them. And also starting with the presumption of good faith, that this person is saying who they are and that they're not hiding anything about the fact that they're actually a drug dealer, that, I'm just going to assume that if they're saying they're in pain and that they need help, I'm going to start with the premise that that's my job. Now, I may occasionally get burned. So occasionally I may have situations where that person actually is up to no good and they are selling it. But my feeling is that I would rather get burned every now and then than the opposite, which is cut patients off who legitimately need pain medication so that somebody suffers. And to me, that's the mindset of reaffirming my role as a healer, not my role as a person in the criminal justice system. You know, some doctors are like, oh, I don't want to get burned. You know, last time that happened, that patient was ended up being somebody who sells drugs. I'm like, look, that's not your problem. Obviously, if you have evidence that that person is a drug dealer, like in the case of Stefan, where they told you they're selling drugs, then of course that is going to influence your behavior. But err on the side of doing the right thing for the person in front of you who tells you what it is they need and what they're going through. And you can definitely do it over a series of visits as long as you don't, as I said earlier, cut them off. As long as you err on the side, because all of this happens under conditions of uncertainty. Right? So under conditions of uncertainty, err on the side of being a healer, err on the side of doing what you think you need to do to avoid a negative outcome for that person, assuming that that person is who they say they are. And I think that's really the philosophy that I would personally like to espouse.
And I think it's interesting too, you talked about making decisions under conditions of uncertainty. There is a lot of risk, and that risk is really unclear how risky it is to prescribe opioids. And this I really think is, again, where we need to be thinking about healthcare at a field level and not just at an individual provider level. Because as an individual provider, if you give everybody the benefit of the doubt and you become the person who is prescribing the majority of opioids in your city, you are actually really vulnerable to law enforcement.
Absolutely.
But if everybody is doing their part, if everybody is seeing some patients who have chronic pain or are on high doses of opioids, then nobody is really vulnerable because then it's the standard of care. It's when the problem I think is the concentration of care. When there's one doctor who's doing everything or one clinic that's doing everything, that doctor or clinic is much more vulnerable than if I don't want to call it a burden, but I do think that doctors often think that opioid prescribing is a burden. So when that burden of opioid prescribing gets spread out across the discipline, then I think you end up with a really different outcome and much lower risk. You're still practicing under conditions of uncertainty, but you've done something to push back on that uncertainty. But once you say, I'm not doing opioids, I'm never prescribing opioids, you are probably not only putting your patients at risk, but you're also making other doctors in your area more vulnerable.
I know that's a great point. I do want to
Wow.
emphasize that this is what this episode is not about is the best approach to treating chronic pain.
Yes.
You
We're
know,
going to come back
which
to
is a
that.
whole nother topic. So I guess what I want to say that this is not a conversation specifically about the best way of managing many of these patients. What I do feel though is it is a conversation about what do we do when we inherit these patients? When patients come to us who are already in this rut where they're on high doses of these medications for a whole range of reasons. And our job is to do the right thing for them and to help them. But I do think your point is very well taken, that it's very hard to be the good doctor in a system that isn't functioning. It's very hard to be a good doctor in an environment where nobody will take care of these patients at all and where you're ending up getting overburdened. I do think that I am able to work with patients who are very demanding and insistent and even belligerent without being strong armed into giving them
Yeah.
opioids, but at the same time, also not cutting them off. And I think that requires a high level of engagement and ability to kind of negotiate the relationship with somebody who might be frightened of losing narcotics and therefore very demanding, or eager to buy and sell narcotics and therefore very demanding. And those can be difficult to sort out. But I feel that by making it clear to a patient that you're interested in having a genuine therapeutic relationship, that you're not going to basically put them out in the wilderness with no meds, but that the relationship is going to have to develop over several visits. I think through that process, you can weed out the patients who are the so-called problem patients, who are maybe not telling the truth about what they intend to do with those, versus the patients who are desperately just trying to get help. And I do think those two groups of people, I think you can separate out if you take the right approach and you demand a relationship over a period of several visits that works in two ways, and that isn't you being bullied or you bullying them. It has to be, you have to basically set the ground rules and say, look, this is going to be a genuine relationship where we work respectfully and caringly with each other. And I think that that is an approach to care that, at least for me, has been very helpful in dealing both with patients who are coming to me for the right reasons, as well as patients who are coming to me for the wrong reasons.
You know, you're really making me think about the mantra of harm reduction, which is meet people where they're at and encourage any positive change. And I wonder, this is a question for both of you. Do you ever name the elephant in the room? Do you ever say to the patient, I imagine you're really scared right now because you really feel like you need this medication and you're afraid I'm not going to give it to you. I just want to acknowledge that fear and then share with you a little bit about what I do in my practice.
I think that I have sometimes probably not failed to ask that question. And, I'm thinking of some recent visits where people were kind of led to believe I would be the opioid decider. Then they saw me and I engaged in a long visit to evaluate the whole history of their pain and all the things that were going on, which very often would not be harmed necessarily by opiates, but wouldn't necessarily be advantaged in the long run either. And I could tell that there was some energy for the patient around what was I going to do with that decision. And I would say this is a serious decision for both of us. It has these weights to it. It's viewed by something I take seriously for your health. It's also something my board takes seriously. But I did not ask the question, by the way, is it possible you're afraid of the decision that is going to come out of this visit? Are there concerns you have about what's going to happen today? And I think I might take that out of this conversation is worth asking.
I think that in terms of kind of tying this all together, what I've learned from talking with you, Liz, and reading your book is that we need to be very mindful as healthcare professionals that there is this tension, that we're working in an environment where it's very easy to police patients. And there are stakeholders out there who would like us to do it. There are Trojan horses that will seduce us into doing it, and that we have to purposefully reaffirm to ourselves on a continuous basis why we're in the room with that patient and what our goals are as healers. And I found that to be a very helpful insight. And as I said, it transcends a number of the conversations we've been having, not just with you, but with other guests.
Liz, do you have any parting thoughts before we close this one out?
Well, I want to thank you both for engaging in such a nuanced conversation about opioids and about policing. I can imagine physicians feeling defensive about the argument that I'm making. And I want to be very clear that I am not pointing at physicians and saying, you are acting like a cop. What I'm saying is, look at these circumstances that are taking you away from the reason you signed up to be a physician in the first place. You got into this to care for patients, and you are in a legal and political and organizational structure that's creating barriers for you in terms of doing that. And so, what can you do, not just in the therapeutic relationship with your patient, but also in collaboration with your colleagues to reaffirm the core of medicine? Because it's the core of medicine that's at risk when we see Trojan horse technologies making their way into healthcare and when social problems like the opioid crisis undermine the work that physicians are meant to do and that they want to do.
Well, I'm super thankful to both of you for this conversation and also to our listeners. For those of you who would like to learn more about Professor Chiarello's thoughts, the book we've been discussing is Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis from Princeton University Press. And thank you both.
Yeah, thanks. Thanks, Liz. Thanks, Stefan.
Thank you both.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.